let's just jump into that. This is a picture I just prepared, and I'm just going to start from here. I have been asked from lots of people, what's the right way of doing, or what is the algorithm to do a fusion? When is OLIF a possibility? When is OLIF a good surgery? And when is other methods are more appropriate? And my best option for you is do the surgery that you are best at. I mean, it's always the number one reason you do the surgery is to help the patient, and your learning curve, your expertise in that is the number one priority. Now, having said that, if your priority is correction of lordosis, and so for some cases it is, ALIF, XLIF, OLIF ATP is the better way to go. If your priority is truly the direct decompression, meaning you need to take the bone off, and I will come back to you, and please catch me, because that is a longer conversation. Certainly, one of those TLIF, PLIF, MIS, endoscopic is the best way to go. But if the efficiency is your priority, especially elderly, patient with high BMI, comorbidities, certainly, you know, Varun and Dr. Vazavada and many others have proven nothing really beats the efficiency. I have here some people that have been in my center, have seen how it goes. You can do in 20-minute surgery, finish to the end, and that gives you an ability to offer this surgery. Dr. Tushar was with us, has seen that we can do a two-level fusion in 45 minutes. That open up the opportunity for you to provide this to people who cannot go through a long surgery. But let's just move on. What I'm going to present is based off, as of last week, 2 weeks ago, we passed 2,000 mark. So we have 2,027 cases. And I'm going to give you expertise at that. And even multi-level fusion, 95% of them are under 2 hours. Now, and this is what I want to tell you as well. I think some of you have seen that. I see Dr. Mayur, lots of friendly faces here. I think what I'm always impressed is how little you need. You don't need $1 million navigation machine. As a matter of fact, look at this. This is all you need to do the surgery. You can do this in any small hospital in Africa. You don't need $1 million navigation machine. You see here, for the first table and second table is what you need for interbody. You see it's an empty table, and the last table is for pedicle screw. The setup, I will offer you all the information regarding how the setup need to be. There are two different setups. This setup is for regular, and this setup for scoliosis. And again, the details has to be in a different setup in the lab. We have a lab coming up soon. We can show it to you. It seemed crowded, but it is not. It's very algorithmic. I admire Varun that can do it with one C-arm. I tried it. I cannot be as efficient with one C-arm than I am with two C-arm. But with two C-arm, I do 7 3-level fusion in one day. And we finish the day at 4:30. But so meaning that even though, yes, you do need two C-arm in the way I do it, but it gives you additional efficiency in the OR. I'm not going to go through the anatomy. Marking at the beginning is important. You will see some of that. With two C-arm, I always see the end point of my instrument. Now, I saw in that fantastic endoscopic that instrument was going through in and out and so on, and then they got the X-ray for confirmation. In my surgery, at every moment, I see exactly where my instruments are. That's one of the advantages, but its advantages, I use more X-rays. But we have a study that shows what that means. So let's just now just jump to the surgery. And I'm going to actually, my assistant has narrated pretty well. Is there a laser pointer here? And I'm going, this is not sped up. This is actual surgery, how it goes. And I'm going to let my assistant, Mitch Ruston, thank you, Mitch, if you're listening to this, just narrate that. But then I'm just going to, with the laser point to the area of the screen that I think is important for you to pay attention. The first screen here is going to be explanation. You will see a picture of the tools. Here is my field. Here is the neuromonitoring that you will see how the stimulation goes. So I use neuromonitoring. Obviously, if you do patient awake, patient is your neuromonitoring kind of situation. But I might do it in general anesthesia, so I have neuromonitoring. And just by the way, this used to be a big deal, but now we have a method that we can get a machine modified, but under $4,000, you can have a neuromonitoring in your center. We have made it possible. Catch up with me, and I give you the details. Here you see the back table, and here are the ORs, and here you see AP and lateral view. So mostly please pay attention to this picture, and sometimes the instruments are flashed up here. Few times only the other are important. So please mostly pay attention to here and here. And here we go. Actually, let me go to a different view here because I want you to okay. I think the voice is not coming out, but that doesn't matter. I can So,
you want sound?
yes, sound. If you have sound, that would be great. Okay, I see that now. That's electricity. Let me put it in for you. I think that's electricity. If you can disconnect it, I have to connect it to the other side. You got it. I got it.
So meanwhile, you can see a regular pedicle Jamshedi is being used to put the guide wire in the pedicle, like the routine MIS screw.
If you see his tech working at the back table,
Okay,
she's currently
here.
emptying the
So I'm
syringe
going to go a little back so you
so
can
back.
watch it from the beginning.
And then through
Mitch,
Dr. Abbasi's
Mitch has done a really good job to explain it. So, can you bring up the volume a little up? I heard it for a second, but then it did go away.
Now that Dr. Abbasi is satisfied with his lateral image, we're going to go in with the AP. If you can see in the OR overhead view, he comes in at directly perpendicular to the patient with his lateral. Then this AP, the base, comes in at about a 45-degree angle, angled cell. He's going to use something straight here to allow his tech to get a straight up and down picture. Make sure what he's seen on the field is the same thing he's seen on his x-rays.
So this is practically setting up the C-arm, and I control it. I think that's an important fact here. If you try to let your assistant to control it.
He's going to center on the area of interest with what he calls the back two, which would be the slide or the in and out, and then the swing or the wig-wag, as some people would call it. Once he's done with that, he's going to transition to what he calls the front two, which would be the tilt and the arc, or some people call it the C.
What's going on here?
So first step, what he has done is put the Jamshedi in the pedicle screw, for the pedicle screw, and that gives us some bone marrow again, to act as a biologic for the fusion, so that you can top up your biologic with that bone marrow. And the first 5 ml from the vertebral body, from the cancellous part, gives you enough osteogenic material to seal
Apologies for
your
that, some
bone
technical
graft.
difficulties.
Okay, that was, I think.
We're back to making changes in the lateral view. Again, centering on 3-4 for this case, one level Olaf.
Okay, we haven't started the surgery yet. This is just a setup. You see
You can
that.
see on the different screens, we have a good view of the field here. We have one that's looking at the back table. This screen here, you're seeing a recording of a TV. So this is actually a projection from the computer of the intraoperative neuromonitoring tech.
So
Now back to the action. Dr. Abbasi is going to start with his markings. First thing he's going to do is make a drawing of the midline using his wire. Now he's going to make a marking showing the trajectory of the disc. Now here comes an important one. In the lateral view, you're going to see he's going to place the tip of his K-wire roughly where he wants the tip of his cage. He's going to mark the base of that. He's going to pinch off the distance from that to what he calls the apex of the curve on the patient. He's going to transfer that distance to the midline. What that will do, and I even have a picture here in the technique guide, it'll give him a consistent trajectory. Like we said, in MIS in general, all the battle is usually in the setup. So now that we've got a trajectory we like, he's got a window for his incision, we're going to get to the action.
this is actual surgery starts at this point, and this is the real speed.
Now he's going in with his Jamshidi. We like to use the Jamshidi first because Dr. Abbasi's graft of choice is a synthetic, and we're going to want to soak it with bone marrow aspirate. The graft itself is a mix of tricalcium phosphate, beta tricalcium phosphate, hydroxyapatite, and some collagen.
These are ceramic. They are not excellent, but with
Jamshidi,
bone
trying to
marrow, they
hit
become
the
really good biologic.
pedicle, about the same time right in the vertebral body. Here he goes. He's going to pull out the inner portion of the Jamshidi. He's going to spin on the luer lock syringe, and this is where we're going to pull out our marrow.
If we take the
Dr.
first,
Abbasi has a pretty thorough protocol for how he likes to soak his graft. Usually likes to give it about 5 minutes. It's
And-
usually a good mid-ground between keeping the graft itself nice and firm while still allowing those osteocytes to penetrate the graft itself.
and we take only the first 5
You see his
cc.
tech working at the back table. She's currently emptying the syringe to soak the graft. And then through Dr. Abbasi's Jamshidi, he placed a wire. We'll use that to place our perk screws later.
So you can set aside the bone graft after seeding it with the osteogenic material and give it time to get soaked in by the time you prepare the disc area.
Dr. Abbasi is making another incision. It looks like he's going to place a couple guide wires before we get into the inner body portion.
Dr. Abbasi, we may need to speed it up a little bit. We can,
Sure.
Yeah, because in the interest of time, we can just jump to
So drill,
the
try to line things up
how
with
you
the
place
EP.
the cage.
And the lateral, you can see on the back table, his assistant has the graft soaked. We're going to put going in again. It's an out bite, so you see he'll point in one direction, pull it out, then he'll flip it at 180 degrees. Pinch the wire with the coker, pound it down with the mallet, take it off, Jamshidi out.
So you potentially have 4 pedicles to get your graft,
And then he's just
osteoblastic
plugging
material.
the small incision he made for the
So
these
you
screw
see the
wires
biologic is
the
soaking in the back table, and now the actual olive
Now here we
stuff
go,
is the
back into the
probe.
probe.
It's going to go very fast. Now,
As many of my friends in the Camden Society are familiar, we're aiming for Camden's triangle. Something Dr. Abbasi usually does, and blink if you miss it. He's going to try and aim for the inferior pedicle, basically the junction of the TP and the SAP, and slide in using some tactile feedback. Now that you got the probe in place, he placed the sheet down. Wire goes inside the sheet to save the trajectory. Now we're going in with the dilator. Dilator goes over the wire, save the trajectory. They'll bend the wire over the top of the handle, so he doesn't have to worry about hitting with the mallet. He can really give her hell. And here we go.
even in the most collapsed disc, once the
Anyway, handle
K-wire
comes
is
off,
in,
so we can slide the
the
access
dilator
portal
goes
over.
in.
This is going to be our working cannula. This is where we're going to pass our discectomy instruments later. The barrel simply goes over the dilator, so we can hit the access portal directly without having to worry about going over the dilator. Bang, bang, bang. In place, aiming for somewhere around the middle to the medial border of the pedicle. Dilator comes out. Now we're going in with the disc drill. Basically a big Archimedes screw. Pretty simple. This will actually do a lot of the work of the discectomy. It pulls out a significant amount of material. It goes in, always spinning clockwise. He'll also use this to size his cage. As you can kind of see in the surgical technique guide, there's 3 notches on the end of the drill. Short, medium, and long. Now he's going in with the expanding paddle shaper. This instrument will point in the direction of the end plates, expand it out, and it actually has some annotations that'll help him measure the height of the cage. So the pass-through instruments are how he's gotten the length and the height of his cage. And if you're looking at the back table, his assistant is already pulling out some cages to load. Always turning clockwise, the expanding paddle shaper helps us create a large space that we'll use some of our later discectomy instruments in later. Now that that's done, I believe this is the pituitary, just pulling out some fragments that we knocked loose earlier.
This is a 10 millimeter working channel, and once that is
You
through
can see he's using the right tech there, just
Cambin's
pull some
triangle,
fragments off
both
the
the nerve
pituitary
roots are
before
now
going in again.
protected, and you don't need to
It's
worry
an
about
outbite,
them
so you see
again and
he'll point
again.
in one direction, pull it out, then he'll flip it at 180 degrees, just like that, get in the down direction, trying to get full coverage.
You can just gently rock this working channel again
Next is an instrument
to
called the
expand your
flexible
area of
grip. This
discectomy.
instrument assembled. This blade here is made out of nitinol. You'll see he's twisting that knob. That is going to expand the loop blade in the shape of a P like this. And it'll give him 13 millimeter coverage up. He'll do a little side to side, again, similar like a ring cap.
And continuous EMG
Very
monitoring,
thorough.
obviously.
You'll see right there what he did is he flipped it 180, so now he's getting coverage down as well, not just up.
So all the way from
flexible, so
skin
he
to
pulls
the
it right out
inside
the
of the
tube.
disc,
And it looks like we're going back in with the pituitary, pull out some of those fragments we knocked loose.
protected with that
That's part of the
tube.
goal of this instrument. It does a lot of the work in the discectomy. Get up bites, down bites. Now he's got the rake. This is basically just a square edge. The articulating fret, you can see it on my screen here, the surgical technique guide. He's basically just scratching the end plates above. Then he's going to flip it around. We're going to scratch the end plates below.
You feel this high frequency vibration in that moment.
Oftentimes you'll feel
You know
a
you're
high
on the
frequency
bone.
vibration here, especially in patients that have maybe a vacuum effect or something. You can actually hear it resonate through the tube. This kind of tactile feedback is very important to Dr. Abbasi. He actually wears one set of gloves instead of two, so he doesn't lose any of the sensation for things like this or when he's going in with the probe, trying to find bony surfaces, keep things consistent. We're with the pituitary again, up bites, down bites, describing the disc fragments we've knocked loose. Here comes the graft. The graft tube has a bevel on the end, so he can be directional if he wants to control the direction of the graft. We're going to go ahead and fill the space that we just removed the disc from. Looks like he needs a little more than was loaded. We're just going to add some more graft.
And as Varun said, don't overfeel it because you may push
Plunge
it
it in,
to
that part's
other
done.
places.
Now he's grabbing a wire. The wire will save the trajectory when he pulls his access portal out. Here we go.
So until now, everything was protected with that tube. Now
And then
this
the
is
last
the
thing we're
only
going to do
time.
is we're going to grab our cage inserter. His assistant would have spun it in, packed it with the bone marrow soaked tricalcium phosphate. And we're going in. It looks like it's possible he's trying to use advanced techniques. We're trying to stick to OLIF 101, but this would be OLIF 301. So the width of the cage is fixed at 9.5. The height is variable up to 15 millimeters. What it looks like Dr. Abbasi is doing is he's going in the lower profile, the 9.5. Perhaps a difficult entry point, you know, the actual final position has a higher height, or perhaps he's trying to spare the nerve root. He's going to pound it in. Small mallet, now here comes the big mallet. Here we go. Usually preps his, who's ever doing his anesthesia and his monitoring tech, just so they know it's coming. Wires out, trajectory's pretty much fixed. He puts it in. Now we're close to our position. He's going to grab the wrench, and he is going to turn it in situ, 90 degrees. Going from the low profile 9.5 to up to a 15 millimeter profile with the height. And because it's titanium, we're able to do that. Now that it's in, he's simply going to spin out the inner portion of the cage inserter. That's going to release the cage, pop it out, and we're done.
Okay, so
Since this-
I'm going to stop here. I want you to see that this is the time is on the thing is one. We had the previous surgeries and so on. This video started at 1 and 1:08. The surgery, the interbody part is actually done, and that is the advantage of this. It's very efficient. Blood loss usually a spoon of 2 spoons of blood. Even in elderly that wouldn't tolerate anything with comorbidities, they can tolerate multi-level fusion this way. Now, obviously, the rest of it is still, we still spend another 10 minutes for posterolateral fusion, but the one-level fusion easily done in under half an hour. And that is the value of the efficiency. Now I'm going to just stop here and maybe answer a few questions. Now, what's important is that you can have it three ways. It's about, I want to go back to a slide that shows it's a group of surgeries that you go Transkembin. You can visualize it endoscopically, that makes it Kailash. In USA, we call fully endoscopic version of that Kailash. Or it can be done the way Dr. Varun Agarwal is doing that, by patient is your neuromonitoring, or you use neuromonitoring, which enables you to do, under this surgery under general anesthesia. I think another thing what's important here is that the posterolateral fusion is obviously as well done under with minimal invasive approach. You don't open it, and there is only one thing I want to show you. If my computer would work with me, there's a tool that we go and grind the surface of the facet. If I can show it to you just a few seconds, if it works with me, that enables you to achieve as well posterolateral fusion, not only instrumentation. So I'm going to stop here and answer questions.